Hello and welcome to Raaonline. Today we are going to learn about pituitary disorders. So in today's installment we are going to learn how to approach anterior pituitary and its various diseases, and today's talk will primarily focus on anterior pituitary hormones and hypopituitarism. So let's get started. So as we all would be familiar with from our physiology days, we know that the anterior pituitary is the pituitary is the master gland which produces a gamut of hormones. Now, looking specifically at the anterior pituitary, it produces prolactin, growth hormone, thyroid stimulating hormone TSH, ACTH, which is the adrenocorticotropic hormone, LH and FSH, luteinizing hormone and follicular stimulating hormone. And as we must be familiar with most of the endocrine disorders, we all know that the most unique feature of these hormones is their ability to exert a negative feedback mechanism. So from the hypothalamus, several releasing factors are released and they act on the pituitary. So these releasing factors act on the pituitary and stimulate the pituitary to secrete several trophic hormones like growth hormone, thyroid stimulating hormone, ACTH, FSH and LH, all of which are in turn going to act on various target glands. For instance, ACTH acts on the adrenals to produce mineralocorticoids and glucocorticoids. FSH is going to act on the gonads to produce the estrogen and testosterone, and TSH is going to act on the thyroid gland and stimulate it to produce the thyroid hormones T3 and T4. Now, these final hormones which are secreted from all of these glands, be it cortisols or estrogen, testosterone or the thyroid hormones, all of them, they are going to exert a negative feedback mechanism on the pituitary as well as the hypothalamus, thereby keeping the hormone levels under tight control. So, let us look at one hormone after another. Let us first look at the growth hormone, because this is synthesized by the somatotropes which constitute up to 50% of the anterior pituitary cells. So, this is the most common type of cell present in the anterior pituitary. So, the peak secretion occurs at night. During the onset of sleep is when the peak secretion of growth hormone occurs. Now, as we all would be familiar with, again, most hormones have a circadian rhythm. So, they may be high during certain periods of the day and they may be low during certain other periods of the day. So, growth hormone, the peak synthesis and secretion happens during the onset of sleep at night. What are the stimulators of growth hormone? Now, growth hormone releasing hormone from the hypothalamus is one of the major stimulating factors for release of growth hormone from the pituitary. In addition, we are able to see that various other factors like ghrelin, estrogen, L-arginine, dopamine, apomorphin, alpha agonist and beta blockade, all of these will also increase the secretion of growth hormone. On the other end, what are the inhibitors of growth hormone? Now, insulin-like growth factor 1, we will learn more about this when I discuss about the growth hormone in particular. Now, it is a factor which indirectly mediates most of the effects of the growth hormone, and this exerts a negative feedback on the secretion of growth hormone. In addition, chronic long-standing glucocorticoid excess also inhibits growth hormone. So, as far as growth hormone is concerned, some of the major stimulators apart from growth hormone releasing hormone from the hypothalamus include ghrelin, estrogen, dopamine, L-arginine, alpha agonists and beta blockers. And inhibitors include insulin-like growth factor 1 and chronic glucocorticoid excess. Now, what is the normal level of growth hormone? Normally, a glucose load suppresses growth hormone to less than 0.7 microgram per liter, and this is going to be less than 0.07 microgram per liter in males. And increased levels are going to be seen in any acute stress like an acute illness or trauma, exercise, chronic malnutrition, fasting, and higher levels are also seen in women, as evidenced by these normal levels here. Decreased levels, on the other hand, are seen in increasing age, increasing weight, obesity, and increasing glucose load. So all of this, increase in weight, increase in age and increase in glucose load, all of this will result in decrease in growth hormone. So this is what needs to be kept in mind. Now, having covered growth hormone, let us look at the different functions of growth hormone. Now, growth hormone, one of the major functions is it induces protein synthesis and increases nitrogen retention. It also stimulates lipolysis. So, on one hand, it increases protein synthesis. On the other hand, it stimulates lipolysis. This antagonizes glucose action, which is why most of the tests include this glucose suppression test, which is where we give a glucose load and see if the growth hormone is suppressed to a certain level. So this tells us that the intrinsic action of growth hormone itself is the exact opposite of that of insulin. And insulin-induced hypoglycemia is one of the strong stimulators of growth hormone. Now, this antagonizes insulin action and hence obviously impairs glucose tolerance, increases glucose levels. Then this increases serum phosphate and also increases sodium, potassium and water retention. As I already mentioned, insulin-like growth factor 1 is one of the factors which indirectly mediates most of the effects of growth hormone, especially on the skeletal system, and this is very essential for linear bone growth. So this is one of the factors which helps in attaining peak height. So having covered this, let us now look at the other effects of the growth hormone which are mediated through the insulin-like growth factor 1. Now, as I said, this is a factor which mediates most of the effects of growth hormone. Now, growth hormone acts on the liver and from the liver, insulin-like growth factor 1 is produced. Now, increased levels of insulin-like growth factor 1 is seen in puberty. Peaks at around 16 years of age. Increased levels of IGF-1 are also seen in women and in acromegaly. Now, decreased levels are seen in malnutrition, cachexia, sepsis, abnormalities in growth hormone secretion or action. All of this will cause decreased levels of insulin-like growth factor 1. Now, what are the actions of the insulin-like growth factor specifically? So, all this that we saw here, increase in protein synthesis, opposite of insulin action causing impaired glucose tolerance, lipolysis, increased phosphate, potassium, sodium and water retention. All of these are primarily actions of the growth hormone, whereas the insulin-like growth factor 1, in addition to this, actually improves the insulin sensitivity. It causes bone turnover. Like the growth hormone, it also causes protein synthesis. Now, what are the adverse effects of insulin-like growth factor 1? It can cause hypoglycemia, hypotension, fluid retention and raised intracranial tension. So, this has to be kept in mind when any patient is on insulin-like growth factor 1 medications.